Hello, everyone. Welcome to our last COVID-19 webinar series of the year. I'm Elisa Bernstein. I'm the Senior Vice President for Pharmacy Practice and Government Affairs here not at FDA anymore, at APhA. I'm really happy to moderate this program, and we really appreciate all of you who have stuck by and attended our sessions through the year, and looking forward to continuing next year. I'm really pleased here to welcome you all to the seminar, and what we're going to do is talk about how pharmacists can test for COVID-19, and then looking at those results, manage patients. And we're also going to talk about what we know about the COVID-19 oral antivirals. And we have some amazing guests today. If you can go to the next slide, we have Teresa Toll. Teresa is the owner of Bay Street Pharmacy in Sebastian, Florida. She's been there for the past 17 years, and prior to owning an independent pharmacy, she had practice experience in chain, long-term care, and hospital. Her professional activities have spanned local, state, and national pharmacy associations, including president of the Florida Pharmacy Association in 2003, treasurer of the Florida Pharmacy Political Committee in 2009, and most recently, the president-elect of APhA for 2022 and 2023. So thanks for joining us, Teresa. And then our next guest speaker is Brittany Harris. Brittany is the co-owner of the pharmacy at Wellington in Little Rock, Arkansas. In 2015, she and her partner opened an independent pharmacy with the idea that they could offer expanded services over what was available in the previous setting. Brittany is committed to advancing the profession of pharmacy and serves on the board of the Arkansas Pharmacists Association and CPSN in Arkansas. As usual, we also have some guest staff to subject matter experts. We have Dan Zlot, who is joining us. He's the Senior Vice President of Education and Business Development at APhA, and he brings over 10 years of experience at NIH as an oncology infectious disease specialist. We're also joined today by Michael Baxter. Michael is the APhA's Senior Director for Regulatory Policy here at APhA. He has a wealth of information and sits on the pulse of all things regulatory, legislative related to pharmacy today. So he'll give you an update on what's going on. Our learning objectives for today are here in front of you. And so I'm not going to read them, but if you can take a moment to look at them. So by the end of the webinar, this is what you're going to know. And we can go to the next slide. So because they're a CE, we have some questions. And here's the first question, and we're going to poll for it. Do a poll, so a pre-test. So COVID-19 testing would be appropriate in the following scenarios, except, and please select one. Question 2, an unvaccinated person who tests positive for COVID-19 disease can be vaccinated, and then select one of these answers. Please vote now. And then question 3, by what % has the oral antiviral molnupiravir reduced the risk of hospitalization and death during phase 3 trials? And select one. Vote now, please. And we're going to go over these at the end in order to get through the CE part of this. So today's format for the next hour, first we just did the introductions. We're going to have a discussion with Teresa and Brittany. They're going to tell you a bit about their practices and some things that they're doing. And then we're going to have an opportunity at about 1:30 to open the forum to questions from you all. So share your questions, share your thoughts, put them in the questions box, and we'll go through those. Right before we end at about 10 of, we're going to hear from Mike Baxter about some of the newest on the regulatory advocacy scene, and then tell you a little bit of other information about what's going on at APhA and what's coming. So these are the ground rules. I'm not going to read them. You know, you could, as I said, submit the questions and comments using the tool. We have information in the handout, also in the toolbar. And at the end of this session, after we go through everything, we'll be giving you the CE code for you to use to go back to our website in order to put in for that CE. And CE is only available during this live webinar. So first, we're going to start with Teresa and Brittany and talk about how they are testing and how pharmacists can test. So let's start with the next slide. And we're going to start with each of you, if you can tell us about yourself. Thanks for coming on. Teresa, you want to start?
Yes, sure. Excited to be here today. Thank you for the invitation and excited to share what we're doing in our community. So Bay Street Pharmacy has been in Sebastian since 1984, so 37 years. We are situated near the Space Coast of Florida, so I just had to send a picture. This was taken outside, I think, in the last 2 weeks. The little dot in the sky in the picture is actually a rocket launch, so right outside my front door. So that's one of the fun things about living here is getting to go out and see the rockets, and it never gets old. And we really love night launches because they're so much easier to see. My bio is a little outdated, Elisa, and that's completely my fault, but I've actually been at Bay Street Pharmacy now for 24 years, 25 years in just a few weeks in January, so almost a quarter century. So I guess I've been out of pharmacy school a while. And after I'd been here for 2 years, I became co-owner of Bay Street Pharmacy and then ultimately bought my partner out in 2005. So I've been full owner with my husband. It is a second generation owned pharmacy. His dad was one of the original partners. So we've been here for a long time in this community and feel very thankful to be able to serve Sebastian. Some of the things that we've offered to help patients with COVID is free delivery service to our community. We also offer all the vaccinations that are available for COVID-19, and we do those in the pharmacy, we do them in the parking lot, and we also go to patients' homes and to assisted living facilities in the community as well. And then finally, the thing we're going to talk a lot about today is testing. So we offer pretty much all kinds of testing, and also, even though you'll see pictures in the pharmacy, we actually do a lot of our testing also in the parking lot. We don't have a drive-through, even though it looks like we could. That's a breezeway. So we don't have a drive-through, so we do a lot of services in the parking lot for patients. So that's a quick overview of Bay Street Pharmacy.
Great, thanks. Brittany?
Thank you. I'm Brittany Sanders with the Pharmacy at Wellington, and as Teresa said, very happy to be here and a part of this today. We opened the Pharmacy at Wellington in 2015, so we've been open for about 6 years at this point, and started with the goal of, being part of the front line and offering whatever services we could. So once COVID hit, we, like Teresa said, did a lot of delivery services. We offered lots of delivery and began COVID testing in the late fall of last year. So we've been doing that for about 15 months now. And then we started offering the vaccines in December when they came out from last year. And we have been doing tens of thousands of them through the store. We've been going off-site to workplaces, off-site to nursing homes, to individual homes, trying to get our communities vaccinated. We're very proud to be a part of that effort. And we recently started offering monoclonal antibodies as well. And have been doing that for the past 3 or 4 months, trying to help our community get well and stay well.
Great, thank you. This is really excited to hear more about both of your practices, and it's great to have you here. So let's go to the next slide. One of the things that really enables you to do more during COVID is the authority that we pharmacists got from HHS through the PrEP Act. Teresa, can you tell us a little bit about that, please?
Yes, sure. So as Elisa said, I'm president-elect of APhA, so I'm going to plug APhA a little bit throughout the webinar today because I'm so grateful for all the advocacy work they do. But definitely this team, Elisa and her amazing team, many of who are on this call today, just being in front of the administration and our any government entities to let them know that pharmacists can do this. So pharmacists were poised and ready around the country, and so it was just great that we were able to be granted this authority. So the first authority we were granted was testing, and that was in April of 2020. Then several other authorities were granted ultimately to reach this therapeutics, which was just granted, I think, in September of this year. But along the way, we also, we were given the authority in states perhaps that didn't already vaccinate children. That was granted to us in the fall last year. And then technicians have been added to that. So a lot of authorities have been extended to pharmacies, and a lot of them have been used through this process because it's been so needed to just meet the sheer demand that is going on in our communities. So yes, the most exciting thing was, or the most recent exciting thing was the addition of therapeutics back in September, and that's indeed what Brittany's able to use to do the monoclonal antibodies. And then, of course, that's going to play in when we get to the antivirals soon, and we'll talk about that a little later.
That's a great overview, Teresa. Yeah, we've definitely been diving all in on this PrEP Act, learning more and doing a lot of advocacy in order to make it the authority more useful and relevant for patients and pharmacists. So what are some of the challenges you faced when you're talking with others, whether it's pharmacists or others, about these PrEP Act authorities?
You know, I think honestly, I think our community has been so excited to have us have it, and I haven't seen much pushback even from like physician community or anyone else. Even with the testing, I think there just has been a demand that hasn't been able to be met. So I think for the most part, it's been well received. We did, you know, the reason they allowed vaccination of children was because they felt that children weren't getting their routine vaccinations because everybody was staying home, right? And pediatricians weren't letting kids in the office, for example, unless they could be tested. So I would say that's the one area I felt was a little tricky. I literally have a pediatrician directly to the north of me and directly to the south of me. So I was a little worried about stepping on toes there, but our pediatricians have been great. And, you know, it's important, I think, for all of our audience to know that as pharmacists, when we get these authorities given to us, then we need to do what we can to communicate to the provider community to let them know what we're doing. So I just said to them, look, we're going to be referring these patients back to you for well-child visits, and we'll let you know when patients get vaccinated. And it was extremely well received by the pediatricians. They were happy to have us jump in and help them and know that our intent was not to take over all of their routine vaccinations. So that was probably the trickiest area, but I would say it really went smoothly.
Great, thank you. And Brittany, you know, in the intro, I know you're going to tell us a little bit more. You are providing a lot of these services, and how have they been received by patients in your pharmacy?
Our community has been very appreciative of the services that we've offered. They've appreciated the quick turnaround on COVID testing and the ready availability of it. We've had wonderful reception. And as Teresa mentioned, communication with the providers has been very important so that they understand we are not trying to take their place. We're trying to be an add-on service. And that's been important in helping the reception from the medical community in our area. We've made good friends with the pediatricians nearby in terms of providing them with COVID vaccines so they can take care of their patients, and just that back and forth collegiality that, you know, maybe we've had, but it's been bumped up a notch with this, and we've taken advantage of communicating our new programs that we're offering. And the physicians have really appreciated the availability of monoclonal antibodies. The ones that are associated with the hospital practice had, you know, more ready availability to it, but the independent providers didn't have that. And now we offer that for their patients. We're an easy way for them to get quick access to the therapy that they need.
Great, thanks. And we'll hear more about that just in a little bit. Teresa, did you have anything to add about patients' perspective on this?
I think I've just been amazed. I literally was in a home last night. The patient said they had lived in our community for 30 years. They never knew we were there. So that, and I'm literally 5 minutes from their house. So they never knew we were in this community. So I've been amazed how many people have found us, and also how many people come back. So they love the service. They love that we're on time with vaccines, doing as we promised with our appointments. And so they're coming back for other things, for flu shots, for shingles, pneumonia. So I think patients are starting to wake up and really see us as kind of a help hub, and I love that. And I really anticipate that we're going to see that more and more as we get more of these authorities and really act upon them. So it's been very exciting.
Yeah, and interesting as we get more, or as we maintain these post-pandemic, which is another issue, but I know there's we are working hard at the state and federal level to do that. So let's go to the next slide. And as I said, a picture says 1,000 words. So Teresa, testing was that first service that you provided to address the pandemic, and it's evolved over the years. So can you tell us a little bit about what are we looking at here, and how has that evolved in your practice?
So the reason this particular patient's in my store is because we were doing a PCR test on him because he's traveling. So we are seeing a bump in that now. We actually have only recently started PCR testing because within the EUA, we're allowed to do it for asymptomatic patients. So this particular patient was traveling and came in to get that test done. So if they're asymptomatic, they can be inside the pharmacy. But if they're symptomatic, they have to stay outside to protect our other patients and also protect our staff. But so we'll do that test. It's a rapid PCR, so it runs in 30 minutes, and then we usually tell them an hour to an hour and a half to give us a little bit of wiggle room. But we provide those results to them that they can, both in paper form and in a digital form. So many times we'll email them, sometimes they'll come back. The other thing that's happened, Elisa, is that early on, and Brittany mentioned how early they started testing, we just didn't have access to supplies. It was really hard to get testing supplies early on, so it did take us a while. But we initially started with rapid antigen testing. It was the first thing we could get our hands on. And then we progressed, obviously, to this PCR testing. And then we have been doing some antibody testing also, so that, that mixes in based on what a patient's requests are and what their needs are, especially a patient perhaps that's not vaccinated and kind of wants to know if they have any antibodies. So we have done some of those as well.
Great. And Brittany, and what about you? How's testing? What are you doing, and how's it evolved?
We started initially, as Teresa mentioned, with the rapid antigen test because that's what we could access first. And we are doing it by appointment, and we're doing it all in our parking lot. So it's all curbside. We have the patients pull as close to the front door as they can, and our pharmacist runs out and does the swab, brings the sample back in, and runs the test inside the store. And that way we're not bringing, potentially COVID positive patients in the store and limiting our staff exposure to those patients. We started doing PCR tests this summer or maybe late spring when those became available for us to use, and we are doing tons and tons of travel testing, and recently started providing those via a QR code, those results, so that there are more and more places asking for QR code results. And so started offering that service as well, and we've seen an increase of people coming just for that service alone. So we are kind of changing as we see the needs and as the rest of the world evolves and decides what's necessary. We are adapting and making sure that we are, ready and there to serve our patients.
Yeah, so I'm wondering, so to the extent that you had to fit this into your workflow, and so you described the actual steps for the test, how does that fit into the workflow of what you're doing in the pharmacy anyway? Because it does seem like it's way more time consuming. Can you comment on that a little bit?
It is more time consuming, and we, during the height of the testing, we had a pharmacist who was pretty much devoted to testing the entire day. When we were running, 100 plus tests a day, it was one pharmacist doing that, running out to a different car every 5 minutes and back in to confirm the results. As testing levels have changed over time, it's not necessarily a full person all day. Like for today, for example, we have about 40 tests scheduled for today, and it's higher because of travel for the holidays. And so for the first couple hours of the day, we have someone devoted to that. And the last couple hours of the day, we have someone devoted to testing. And then during the day, as appointments pop up and pop in, we'll have a pharmacist run out to the car, slide out of workflow for 5 or 10 minutes, and come back in and rejoin workflow. So it has definitely changed the process, and it's changed over time as the demand for testing services has changed.
I have a follow-up to that too, Elisa, if I may. So I think it has really pushed appointment-based model in the community pharmacy setting. I can say that we were a little bit lax about that prior to COVID, but we have to have appointments now. So we block appointments for immunizations and testing. We too have at least one dedicated person and sometimes two. And a lot of times we're side by side doing both. So one person's vaccinating and the other person's doing testing. Fortunately, we too have cross-trained a lot of our staff. So if one of us is unavailable or has to step away for a meeting, imagine that, then there's somebody else who can cover and go do that test. So it has been really, really helpful. We have not yet utilized technicians, but I know that technicians can be utilized in some of these roles as well. So I know that some pharmacies are definitely doing that also, but I'm definitely using that appointment-based model. And in my case, we've done a lot of paper appointments because we have a very elderly population. And honestly, it's one of the ways that we really served our community early on, because they couldn't schedule appointments with the chains because they couldn't figure out their systems. But we're getting to the point finally where we're going to get it all automated and train our staff that if the patient can't do it, that we'll do it for them. So we're real close to having that launched, but definitely has made us automate and do these appointments.
Well, it certainly sounds like because of that workflow impact, having appointments is really critical, particularly not just for you all, but for the benefit of the patient, so they're not waiting for a while. So that's great. Well, let's go to the next slide and talk about how you determined who should get tested and which tests to administer and to whom. I'm going to throw it out to either of you.
Brittany, you want to go? Go ahead.
Sure, okay. So some of our is by self-selection. So if a patient needs a PCR test for travel, obviously we want to provide that PCR test for travel. It's the patients who are, having some symptoms that maybe need a little extra guidance as to what, why, the reason behind their testing and what tests they should do. Patients who are showing symptoms and have had a known exposure, we usually tell them, that an antigen test should be sufficient to meet their needs if they are symptomatic. If they are just truly want a yes or no answer, we tell them, the PCR is the gold standard. It's more sensitive than the antigen test is, and it's, we'll give them a more affirmative answer, yes or no. But we do choose tests that have high sensitivity and high specificity, so we know that our patients are getting the results that they expect to be getting from us. We also encourage patients who are symptomatic to also test for the flu, because there are still other respiratory illnesses out there, and if they are symptomatic, it could be flu or COVID, either one pretty easily. And we've seen a lot of patients who have tested positive for flu who came in initially only wanting a COVID test. So, we're able to catch that and hopefully help people get treatment faster than they would have otherwise.
So So our process is very similar, and I think it's important to note that sometimes we talk patients out of testing. Sometimes they're just simply not good candidates. So, we have a conversation with them about how long they've had symptoms, what their symptoms are. In Florida, we get a lot of just a runny nose and a little bit of a cough, and it's probably an allergy, so we might have them wait a little bit longer to get tested, but, they need to have symptoms that make sense, and or a lot of times they come in and they were exposed the day before and they want to get tested, and that's completely not appropriate. So so that as well. We do have a combo flu and COVID antigen test now, so we can use that as well. And then PCR testing, typically reserved maybe more for a confirmatory test if the antigen test comes back negative and we have reason to think that it should have been positive. So PCR tests, because they're more expensive, reserved more for that, or for patients that are traveling.
Great. Yeah. So what we have here on the slide is very consistent with what you said. This is CDC recommendations in terms of if you're symptomatic, get tested. If you came in close contact with someone with COVID-19, get tested. If you're not vaccinated immediately, if you're fully vaccinated, wait 5 to 7 days. And if you're not fully vaccinated against COVID, there are recommendations as well in terms of prioritization for screening. And the key here is also if you have tested positive for COVID-19 within the past 3 months and recovered, you do not have to be tested as long as you don't develop any new symptoms. So this is all CDC recommendations, and sounds like you both are following that as well, whether you know it or not.
We're trying. that would be the goal.
Yeah. Yeah, so if an unvaccinated person comes to your pharmacy and tests positive, what do you say? What do you talk to them about in terms of whether or not you have a relationship with them?
So I guess, first of all, on our screening form, we do ask if they are vaccinated, really kind of more for our information. It's not, we have to report to the state of Florida all lab results. So we do ask a lot of questions for that reason. That particular question is not on the state of Florida questions, but we do it for our information specifically for that reason, Elisa, to allow us the opportunity to have that conversation with them. So if they're unvaccinated, sometimes that's not the first thing they want to hear when they test positive. So you really want to show your pharmacist sympathy and talk to them about ways to get treated, and if they could treat at home, or if they might be sick enough to indeed seek the monoclonal antibodies and oral antivirals if those come along, or perhaps even be referred. I don't know about Brittany, but we have a pulse oximeter in our little testing kit, and I have actually tested oxygen levels. I had a patient one day that had 82% saturation and told them they needed to go straight to the ER. So, it depends on that, but certainly if they're open to it, it does give us the opportunity to talk to them about considering getting vaccinated, and we can explain the guidelines to them that they can get vaccinated. I think it's on here as soon as they've recovered, if they want to, or they can wait a little bit longer. And we talk to them about the monoclonal antibody treatment as well. So it really, a lot of it depends. And I mentioned the antibody testing. So sometimes that's a really good way to have a conversation about vaccinations too. If we do an antibody test on someone, it gives us a way to have a conversation about why they might want to get vaccinated.
Great. And go ahead, Brittany.
Well, I was just saying, I agree that, the people who come in for an antibody test who are generally more open once they see that if they don't have antibodies, they thought, oh, I had COVID perhaps 6 months ago and just never had a positive test. But when they see that they don't have antibodies, that really does kind of open up a conversation that they're more willing to have at that point, and consider being vaccinated, where maybe they weren't 15 minutes before they knew the answer to that test.
Great. And so let's talk about negative test results. What do you recommend if a patient ends up with a negative test result? Yay, it's negative. Now what?
You want to go first this time, Brittany?
Sure. If this is a patient that was here because they were symptomatic and they've only tested for COVID, we do remind them that there are still other causes for their symptoms. There are, possibility of flu, there's possibility of strep, there are still other issues. So if they're not interested in testing for flu at that point or strep, then we ask them to follow up with their doctor and still to exercise caution and avoid contact with others while they're exhibiting a fever, other symptoms that they are concerned about. They still need to, even if it's not COVID, they still need to practice, those good social precautions. The patients that are not symptomatic and we're just testing for exposure, we again ensure that they were testing at the right time frame, because a lot of people want to, as Trish mentioned, just jump and get tested the first day. And some employers we're seeing are even asking that their patients or their employees be tested that first day, even though that's not guidelines and that's not what we recommend that they test at the appropriate time frame. And so just kind of depending on what the situation is, why they were there. If they're traveling, we say have a safe trip. We're happy you're not covered problems today.
Yeah, I don't have much to add there. We do exactly the same thing. And I think the only thing we might do is a confirmatory PCR test, perhaps, if we really think that there's some reason that they probably should have tested positive. But I agree with Brittany about all the other types of viruses that could exist or bacterial infections, and they might consider doing that as well.
Great. And so let's move on to monoclonal antibodies. And Brittany, I know you're doing that, and I know you're in a location where you can't remove your mask, but if you can speak just a little bit louder, that would be really helpful. So tell us about your monoclonal antibody treat part of the patient care.
Yes, so we started treating with monoclonal antibodies about 3 months ago when this initially became available. Arkansas was one of the first states to roll out this opportunity to pharmacists. And we were fortunate to be able to acquire a separate space in our same center that allowed for keeping COVID positive patients separate from our everyday pharmacy patients. And so we've got a space that has separate patient rooms set up, and we provide the monoclonal antibodies by subcutaneous injection. And we have had a very good reception from the community. We either have patients who we have tested, who we self-refer or self-screen and inquire whether they're interested in this possibility, or we have referrals from other local physicians or from even hospitals where they have met their capacity for antibodies for the day and they've got overflow patients that they need to get taken care of. So we are, some days we'll do 2 or 3, some days we'll do 15 or 16. So it just kind of depends on the caseload that we see in the community and the need that's out there. So we've been able to establish through the same scheduling system that we're using for both vaccinations and testing. We are using that same scheduling system to schedule our antibody patients. And we tell them to plan to be there for about 90 minutes. And we schedule either a couple or an individual every 30 minutes, basically, is what our workflow allows for. And we have the pharmacist that screens the patients and makes sure that they are a good candidate based on their underlying health conditions and their vitals. And then either the pharmacist or we have some nurses on staff that will provide the actual injections to the patient, and then monitor the patient for about an hour after they are given the injections to make sure that they don't have any sort of allergic reaction or side effects from the injection. And then we schedule a follow-up with them at 24 to 36 hours just to make sure they're doing okay and there's not any other cause for concern or we don't feel that they need follow-up for additional reasons at that point.
Great. And do you do referral? Do you refer them back to their primary care doctor or practitioner?
So we do ask that they follow up with their primary care doctor, particularly if they're having other concerns or if new symptoms develop or something worsens. We do absolutely encourage them to follow up with their primary care provider and make sure that they know that they had this therapy and that they are, either recovering or not recovering at that point. But we've had very good results from patients who have had the antibodies. We've seen very positive results for the patients.
And this is great. This is fascinating. And I know that you were able to get it. You explained that you were able to get this new space. What was that? What was the turnaround time though to get you got the space? Your first patient came in. What was that time frame?
It was pretty quick. We really kind of pushed once the data became available. I think we got the space on maybe Friday, and we had patients in there over the weekend. So it was we worked to make it happen. We knew that we needed to do this for our community, and fortunately the space didn't need too much work. In fact, we were providing the antibodies in our vaccination center even prior to taking possession of the space. So it was we had kind of turned our vaccination center into an antibody. Again, it was separate from the pharmacy, and we just rolled the vaccines back into the pharmacy at that point based on the volume of vaccines. So it was
great.
It was a very quick adventure, but necessary.
Well, it's very impressive. It's really great to see pharmacists doing this in the communities. Let's go to the next slide, because I'm looking at the time and I want to leave time for Q's and A's, but I want to talk about another part of TREAT, and that is oral antivirals. And when we planned this webinar, we were thinking, hoping, expecting that maybe there would be an authorized oral antiviral for COVID-19. There isn't one yet. We do know that the FDA has applications in for 2 oral antivirals for COVID, one with Merck, molnupiravir, and that's pending, and an advisory committee meeting was held, I think it was about 10 days ago, 2 weeks ago. And the data showed that it reduced the risk of hospitalization and death by about 50%. So we're waiting to hear from FDA. There were some safety concerns related that the advisory committee noted. And then the Pfizer product is also still being evaluated by FDA for authorization. And as Teresa was talking about the PrEP Act Authority earlier, just a while ago, that the great thing is a PrEP Act Authority allows pharmacists to order any authorized or approved or cleared COVID-19 therapeutic, including oral, IM, or sub-Q. So the oral would qualify depending on the terms and conditions of the EUA. So we're waiting to hear that, so that all that they're talking about test, and then the treat, whether it's a monoclonal antibodies like Brittany is doing, or oral, which is a lot more convenient and pharmacies are more accessible. But we have heard that, at least for the Merck product, that distribution is going to be very limited because the government has only purchased a small amount of the drug that will be distributed across the country. So, Teresa, can you tell us a little bit about Florida's test and what are you planning to do there? Because Florida already has a test and treat authority. I know it was just right before the pandemic, but what do you planning to do in your pharmacy for COVID antivirals?
So yeah, Florida does have a test and treat, which is exciting. It does require 20 hours CE, and you have to establish a collaborative practice agreement with a physician to do that test and treat. We're allowed to treat minor ailments such as flu and strep, actually, if the doctor allows it under the CPA, and can prescribe. So we can prescribe antivirals such as Tamiflu, can prescribe antibiotics such as amoxicillin if it's pertinent. So anyway, that's what's happening in Florida. So exciting stuff, and we're finalizing our CPA, but we're excited and ready to go there. As far as this, I mean, certainly trying to work with our local health department to try to make sure they know. I'm also a CPESN member in Florida, so trying to obtain antivirals through that process as well. So we will see what happens as far as availability, but we are poised and ready to provide these if we can get access to inventory.
Great. And Brittany, what about you at your pharmacy? She may not have heard. Yeah, so Brittany, are you planning on setting up some sort of test and treat model now that you're testing and treating with monoclonal antibodies? Are you doing anything to prepare for the oral antivirals? She is muted by the organizer. So if we can unmute, let's just move on and we'll come back to you. Can you talk about, can you talk yet? Nope. Well, looking at the time, let's move on to the next slide. Yep. Oh, there, now you're on.
I think I'm back.
Yeah.
We are working through CPESN to acquire the oral antivirals as well. And we have a similar model in Arkansas where we are able to test and treat now for COVID through the PrEP Act, and we are getting that across the board in January. So we're excited to be able to do that a little more broadly. But we've been told by our health department that it will be people who are sites that are open 7 days a week and willing to provide therapy 7 days a week initially, because there will be a fairly small amount of the product available initially.
Great. Well, I'm going to finish up to get to the Q's and A's. Let's touch on reimbursement, because it's a really important issue and question. So can you just talk a little bit about what pharmacists need to know and your experience?
Sure. So again, wearing my APhA hat, I want to give a shout out to this team for all the work that they've done. I don't know if everyone watching today knows how frustrating the process has been for reimbursement on antivirals, but there has been so much advocacy work that has been done by APhA and other national organizations to really fight for pharmacists to have reimbursement for not just the dispensing of this product, but the clinical service that goes along with this. And y'all have heard how involved the testing is, and then diagnosing the patient and then dispensing and then counseling them. It's going to probably take 30 minutes at least to do this. So pharmacists need to be paid for their service in addition to just the dispensing. And it's a message that all of you should be advocating for as well, but I'm just so thankful for this team that does it. As far as for test and treat, we have been exploring different ways, but right now patients are paying out of pocket for the test and treat for the same reason, because of the reimbursement for the service and the time that's involved.
Great, thanks. Anything to add, Brittany?
We are running the same model in terms of patients paying for the service at the moment. We are able to bill for the antibody therapy, and so it is a complicated process, and payment seems to be very slow. But we are working on that in order to try to offer additional services for our patients.
Yeah, that's what we're hearing from other pharmacists and members as well, is you can bill for it, it's just the payment is not coming through, whether it's slow or still waiting, some challenges there, but hopefully that also will get sorted out. So let's move to the Q's and A's. I know there are a bunch coming in, and I'm just gonna start with, I guess, both of you. In terms of the testing, we had a question about reporting. One of the things with COVID is everything needs to be reported to somebody, sometimes duplicate. What are you doing for reporting for testing with respect to local county, state, federal? Yeah, let's start with that. And also, actually, the same person asked a question of, do your tests allow you to distinguish between the different variants, COVID-19 variants?
So we are reporting through the state of Florida. We actually have an electronic portal that we can log into to report. It takes only about a minute to do reporting. We have looked at an automated system that would do our scheduling, and then at the end we could put the result in and then it would report. So there are those technologies out there and we're exploring them right now, but right now we're doing our own reporting. No, the tests don't distinguish between the variants. I don't think that there are any types of point of care testing that do. My understanding is that's done more through surveillance, but the experts at APhA can probably answer that question, but I don't think any of them do distinguish on variants.
Great.
I'll just say we're the same. We report to our health department as well.
And on the note, a question came in also about reporting and looking at databases related to the vaccines. So when the patient comes in and they don't know if they may, you don't have any information about whether or not that they've been vaccinated, do you then, are you able to look at your own state databases and to look and see if a patient had already gotten the 2 or the booster?
Yes, we do. And actually, I'm not comfortable giving a vaccine without having their card or being able to go and check that. So if I don't have their card, the first thing I'll do is go look at at the IIS, and it's called Florida Shots in our state, and just see what doses the patients had and when, because we're doing our best to follow the guidelines on boosters, 6 months for the mRNA or 2 months for Janssen. So yeah, we definitely access that. And then if we can't get answers there, then we might call a provider where they got the vaccine. I've had to do that, actually call some local clinics and say, you're not reported, the patient said they got this dose, I need to know, and they'll go find it for us and call us.
And what about, oh, I'm sorry, go ahead.
No, go ahead.
I guess for either of you for testing, are you doing actually, I think it was Teresa, you mentioned that you do antibody testing. The question is are you using quantitative results? And when you get that, what do you do? What do you tell the patient?
One of the things that I think we tell patients is that antibody testing probably still has a ways to go, but it's essentially a positive or a negative result. It is not qualitative. There are labs, so many patients can get their antibody levels ordered through a lab such as Quest or LabCorp, one of those. But even those numbers are tricky to interpret. There doesn't seem to be a lot of great information. Ours measure IgG, IgM, and IgA, and it just simply gives us a positive line, a lot like what our antigen test looks like. I always tell my patients it looks like a pregnancy test, but that's how it works. And it is a blood, it's a finger stick, so it's a blood test for antibodies.
Great, thanks. And so we actually got a question. I don't know if anybody if you know this, or if anyone from our APhA staff, can someone continue to test positive even when no symptoms exist and they've already quarantined for the 10 to 14 days? Do you know the answer to that? Dan, thanks for joining.
Yeah, absolutely. So the answer to that is absolutely. There are certainly circumstances where that's happened, and there's a lot of different variables that go into that. So the ability for people to continue to test positive depends on the rate of viral clearance as well as viral shedding. So if for some reason, maybe someone's a little bit immunocompromised, as an example, it may take them longer to clear the viral infection than someone who's fully immunocompetent. And so that could be a situation where you might see them continue to test positive, even though they've not had significant symptoms and they've been quarantining. The other element that goes into this is, of course, the sensitivity of the test that you're using. So especially some of these PCR tests, the lab-based ones can be very sensitive. Some of them can pick up very, very small viral quantities. And so it's a possibility that you may actually have a viral particle or two sitting, in your testing site, whether that's your nose, your oral pharynx, et cetera, and that gets picked up, even though that's not enough to necessarily cause disease in the individual or even to be transmitted. But all of those things could potentially result in a positive test even after 10 to 14 days and no symptoms and quarantining.
Thanks so much, Dan. Really appreciate that. Great information. There was one question I'm going to answer. When do we anticipate actual availability in the U.S. for both oral products? We are waiting at the edge of our seat for FDA for the one product, for the Merck product. FDA heard from their advisory committee about 2 weeks ago. It seems like they're evaluating and really taking to heart the information that the advisory committee came up with. It was a very close vote because of some of the safety considerations. For the Pfizer product, it still has not gone to the advisory committee yet. So we anticipate that will also be scheduled soon. And then again, shortly thereafter, usually FDA makes a decision. And I'm looking at the clock, and I'm also looking at all of the questions and information you all are sending, telling Teresa and Brittany how fabulous, what a fabulous job you guys are doing in your communities. They're so proud of having you as pharmacists in terms of what you're doing in the practice, and really excited to hear what you've been doing. So thank you so much for joining us today. Keep what you're doing. Keep on keeping the fight and making us proud as pharmacists. So thanks a lot.
Thank you.
We're going to now move into a little update from, I'm going to bring on Mike Baxter from APhA. And Mike, can you give an update on what's going on? Thanks.
Sure, I'll be really quick. Just to repeat from Teresa earlier, with the oral antivirals, we've done a lot of work to get authorized for pharmacists to order and prescribe and administer the oral antivirals. We're waiting for the EUAs to come through, as Lisa mentioned. In between, it's kind of like if you build it, they will come. If you reimburse it, pharmacists will offer these services. We've run into a little snag here from CMS, which runs Medicare and Medicaid. They put out a memo to the states actually for the Part D plans under Medicare, encouraging them but not requiring them to cover that clinical service to actually determine whether somebody's eligible to receive the oral antivirals. So we sent a letter to the National Governors Association urging the governors to kind of step in here and step up and use their full authority to provide a payment pathway for patients to receive the oral antivirals, at least on the Medicaid and commercial plan front. So we'd really appreciate all of our members reaching out to your state officials and also your state governors to help us on that front. And just really quickly, in a breaking news segment, if you're interested in the DIR fees, the direct and indirect remuneration or clawbacks for community pharmacies, we received notification yesterday from a number of members of Congress that there is going to be a regulation coming out from CMS to deal with that issue. But again, the devil's in the details, so we'll report to our members on all the updates as soon as we have them. Now I'm going to turn it back over to Elisa.
Thanks so much, Mike. Yeah, the advocacy and issues just keep on coming. Nothing slows down, even with the holidays coming. So we're gonna, APHA's team is gonna keep monitoring and provide information for you as it happens, even during the holidays. So we want to also remind you that the Pharmacist Guide to Coronavirus has amazing information. I'm a little biased, it's amazing. It's on testing in pharmacies and COVID-19 therapeutics. It supports a lot of the information that Brittany and Teresa shared with you. So please feel free to visit those websites to get more information. And what you'll find there is information about these are some of our resources that we provide. We've been updating some information, particularly with new booster information. There's algorithms that you can use to help determine what's the right booster for the patient, and more information about the various vaccines. We can go to the next slide. Engage is APHA's Engage platform is a great place for you to share information and exchange ideas with other members. So just a reminder, please make sure you're signed up and use that. And join us on January 13th, our first webinar of 2013 of 2022 at 1 o'clock. So we'll be sending out more information about that. Let's go through our assessment questions. COVID-19 testing would be appropriate in the following scenarios except, and if you can vote now, please. All right. Yep, 92% of you got the right answer. If you were tested positive for COVID-19 within the last 3 months and have no new symptoms, you do not need to be retested. Number 2, an unvaccinated person who tests positive for COVID-19 disease can be vaccinated, and choose one of these. And the answer is, well, 73% of you got the correct answer, that they can be vaccinated as soon as symptoms resolve and it's safe to do so. And number 3, by what percent has the oral antiviral molnupiravir reduced the risk of hospitalization and death during the phase 3 trials? And the answer is B, 50%. So 88% of you got that correct. And I am going to do a plug for our executive residency program. We are taking applications until December 31st. The information is on our website. You can scan that QR code. Please share this opportunity with anyone you think who may be interested. It's a great opportunity to learn about pharmacy association management. Thank you so much for joining us. Have a happy new year. Have a wonderful, safe holidays, and we'll see you on January 13th. Bye.